Overview of the presentation is I'm going to start with 3 case presentations that will kind of show you where we are currently in terms of the state of the art in neurovascular care. So I think one of the easiest ways, to understand, what's going on in medicine these days is sometimes through case histories and case stories. And so let's start with our first patient. And this is a patient with ischemic stroke or large vessel occlusion. 79-year-old man. He experienced an episode around 10:30 while he was watching TV where he had difficulty getting up. He felt like he couldn't lift his legs. And he's with his wife. His wife thought his speech appeared a little garbled, not quite articulate. And he was having trouble getting his words out. She thought he might be drooling out of the right side of his mouth, but she didn't see a facial droop. And which was very interesting because she was looking for this, right? She knew what the signs of a stroke were. She was looking, does he have a facial droop? Is something wrong? And so he ended up, bringing him to the hospital. When he got to the hospital, he had returned to normal. He didn't have any dysarthria, no facial droop, no weakness. Stroke scale score was 0. And so the stroke team, decided at that point, no IVTPA. IVTPA we give within 3 hours, 4.5 hours, depending on the circumstances. But he was a TIA, and so loaded him with 300 milligrams of Plavix. This was 12:30 at night, and observed him and ordered an MRI for the first thing in the morning. So he was getting his MRI at 6 a.m. You can see on the top left image a small diffusion abnormality within the subinsular insular cortex of the left frontal lobe. And that's all we're seeing. And on this perfusion scan, you can see that there's a large territory of at-risk brain in that left MCA territory. Because what the MRI showed was that there was a lack of flow within that left MCA middle cerebral artery. As he was getting out of the MRI, he suddenly progressed, right? And became completely paralyzed on the right side. Did not have an aphasia or gaze preference, but he was severely dysarthric and right-sided paralysis. So at that point, we got an emergency CTA, brain perfusion study. And so here on the CTA on the left, we can see that there's a tremendous amount of calcification within the aorta, which is not uncommon in an older gentleman. And we can see on the right side that the carotid artery on the white line is going all the way up into the right MCA. On the left, he's missing his left internal carotid artery in the cervical segment. And then when you look intracranially, he also has a second occlusion in the M1 MCA segment where that red dashed line shows where the blood vessel should be going. And so basically he was experiencing a tandem occlusion in the neck and in the brain. The brain perfusion study shows that entire left MCA territory has prolonged perfusion time. So it's, basically because of the blockage, it's taking a very long time for the blood to get to the brain. And it's not adequately getting to the brain. On the right, we're looking at what we call the cerebral blood volume map. And that gives us a little bit of an idea of what may be irreversible brain injury. Brain tissue that is damaged beyond recovery. But we can see that the territory at risk is much larger than the area that looks like it's permanently damaged. So this gives us an opportunity to potentially save a lot of brain tissue and give this patient an opportunity to potentially improve their functional outcome. So we rapidly brought him to the neurointerventional suite, and the initial angiogram confirms what we saw in the CTA, that there's a complete occlusion in the red dashed line of the left internal carotid artery in the neck. And so we needed to get through there if we were going to start to revascularize his intracranial blood flow. On this study, what we see is what I needed to do was, first of all, aspirate thrombus in the neck occlusion, and try to remove the thrombus, and then perform a gentle angioplasty to open up a channel. And so initially, what that left-sided image shows you is the result of after the initial angioplasty of that left carotid occlusion. But then you look up in the brain on the right-sided image, you can see that there's the occlusion of the left MCA. So yes, we've opened up the neck, but the target vessel, which is the MCA, still is occluded. So then we proceed to the left MCA, and using aspiration thrombectomy, which is one of the very major innovations that over the last 10 years, Penumbra, as well as a variety of different manufacturers and researchers, have developed a variety of different tools, including stent retrievers, aspiration thrombectomy, et cetera, to now remove blood clots from the brain vessels. And so we were able to very quickly restore complete perfusion in this gentleman. And we can see that his MCA branches have been revascularized. And then on the way out, to maintain that neck occlusion open, I deployed a stent, which you can see is maintaining a nice lumen, throughout the course of that occlusion. Clinically, he made a complete recovery with reversal of his right-sided paralysis, complete fluent language comprehension, visual fields, and a stroke scale score of 0, which I think highlights that there is a tremendous opportunity, to potentially save brain tissue in patients, experiencing stroke. And there's a variety of factors that go into it. It doesn't always work this well, but we are finding that as we're gaining experience, selecting patients properly, and treating them in a rapid and appropriate manner, we can achieve these good results. And he went home 2 days later, which would otherwise have been a devastating left MCA stroke. In follow-up, 3 months after, I was very curious because he'd done so well. I wanted to get an MRI, see if he had any permanent brain damage. The MRI shows no permanent brain damage, and on that top left image. And so I think these criteria that we look at, these perfusion maps, parametric maps, which I've done a fair amount of research over the years on, are still, giving us an idea, but they don't necessarily predict with a high level of specificity, what the outcomes are. And I think that's something that remains evolving, and I think we can continue to improve. If you look at the need to treat, which I think everybody here knows, right, is a very important number, right? If you look at something like aspirin or statins to prevent heart attack, it's like a need to treat of 200, but those are the standards of care, right? IVTPA was a need to treat of 9 within 3 hours, and within 4.5 it was 20. If you look at the endovascular interventions, you can see that all comers, the need to treat was 7 for the first trial, MR clean. And then as you go down the list of those trials, you see that we got more selective, but we also extended the time window, right? So, but the need to treat comes down to if you have favorable perfusion profiles and up to 24 hours, you can treat 3 patients to save 1. 2 patients to save 1, right? And so this is about as strong of an effect in medicine that you can get, And so I think this is the standard, this is what we're doing. Comprehensive stroke centers have become the standard of care, and our teams are very good at handling these types of patients. And so we're very excited. I think this next patient kind of highlights, what we need to do to prevent these large vessel occlusions, and so this is carotid disease. And so when we look at this patient, 60-year-old woman, she was woke one morning not quite feeling normal. She's having trouble, buttoning her button, a little unsteady on her gait, and her family noticed the left facial droop, and so she came to the hospital. When our team talked to her, she said maybe her symptoms started, about 9 hours ago, but she also had something similar maybe 3 weeks ago, which had kind of gotten better, So we were unsure, so she was not a TPA candidate. Stroke scale score of 3, mild weakness of the left side. And the initial CTA examination, if you can see where the circles are, that is the right ICA, 99% stenosis. And you can see that the carotid artery on the right is much smaller than the left because of the stenosis causing flow reduction. When we look at the brain perfusion scan, we can also see that on the right hemisphere, there's very much prolonged time to perfusion, and the cerebral blood volume is elevated, which is a sign of ischemia. Collaterals trying to recruit, but the CBF is being maintained by those collaterals. So she's on the edge of hemodynamic perfusion failure. So with drops in blood pressure, she was experiencing ischemic injury. The MRI obtained at that same time on the left shows you the diffusion abnormality within the deep white matter of the right hemisphere, which is the triple watershed of the MCA, ACA, PCA territories. So essentially she was relying on that 99% stenotic vessel to give her the trickle of blood that was trying to sustain her. And she was in the process of having a major stroke. And the angiogram here confirms the 99% stenosis, as well as on the right-sided image, you can see how the vessels of the extracranial circulation are filling much quicker than the vessels in the intracranial circulation because of that flow-limiting stenosis. And this is a particularly challenging carotid revascularization patient because of the severity, because of the perfusion failure, and also because of the extent of the plaque. This plaque extended all the way up to C2, so it's a very long plaque, not an easy surgical candidate. And so in this case, what we did was I pre-dilated with a small coronary balloon. I went to one of Dr. Malhotra's colleagues' labs, to grab a small coronary balloon, to slowly pre-dilate before we could even put up our embolic protection filter. Yeah, and then after we pre-dilated, we put up the filter, did a more brisk angioplasty of the lesion, and then put a stent across. And you can see the result there. And we've covered the entire lesion all the way from C2 down to the common carotid bifurcation. And she also improved, fortunately, within a week, was discharged from the hospital with only a mild nasolabial fold flattening, and within a month, she was back to all of her activities of daily living and an MRS of 0. And the third topic that I wanted to cover in terms of clinical was hemorrhagic stroke and brain aneurysms. This patient that we'll talk about to illustrate our advances in this area is a 53-year-old woman who was actually in rehab for recovering from a recent orthopedic surgery on her shoulder. And she suddenly lost consciousness while working with her physical therapist. She woke up, she regained complete consciousness within a few minutes, but they called the ambulance, and then once she was in the ambulance, she fell into a complete coma. When you look at the initial CAT scan when she presented at the hospital, you can see all of this white star-like configuration you're seeing on that CAT scan is all subarachnoid hemorrhage or blood. And all of her brain was very tight, effaced. We would see evidence of early tonsillar herniation, and so she was, at the point of potentially dying and becoming brain dead. So we intubated her, stabilized her, hemodynamically, and then brought her to the cath lab and performed an emergent angiogram and identified 2 aneurysms in her case, which is particularly confusing and challenging. Because if you look at the pattern of hemorrhage, it's everywhere. So the question becomes, which aneurysm ruptured? So these are the 3D angiograms that we obtained, and you can see that there's an ACOM aneurysm, or anterior communicating artery aneurysm, which lies in the midline, as well as one in the right ICA clinoid segment. But when you look at the aneurysms, you can see that the one in the anterior communicating segment in the midline has a little bit of a nipple on it, a little bump, which makes it more suspicious for being the rupture site. Also, when you look at the blood pattern, there was quite a bit of clot, focal clot, within the anterior interhemispheric cistern, which made that more suspicious. Now, and so we decided that even though that was the smaller aneurysm, it was probably the more likely to be the one that ruptured, and that was the one that needed priority treatment. Nevertheless, the other aneurysm, we weren't 100% sure it could not have ruptured. And so we decided what we were going to do was, if possible, treat the ACOM, or the smaller aneurysm first, and then come back in the same sitting and treat the second aneurysm if it was able to be done safely. And so rather than take the patient to open surgery, which would have been 20 years ago the traditional approach, especially with a high-grade patient like this who's in very critical condition, we felt that the endovascular approach, if possible, would be the best approach to handle these aneurysms. And so you can see on the left that we are navigated into the anterior communicating artery aneurysm and have placed coils within that aneurysm and have blocked that off. And then as we pulled back, we navigated into the right ICA clinoid aneurysm and treated that aneurysm at the same time and completely occluded both. She spent 14 days in the neuro ICU, and where we managed her hydrocephalus. We managed her vasospasm and treated that as well with intraarterial medications. And obviously cardiac and respiratory care are critical in these patients. And DVT, seizure, their ID prophylaxis. And after a week of acute rehab, she was able to return home. And I just saw her in the office a couple of weeks ago. She's about 2.5 months out. She's back to all of the activities of daily living, and I think she's looking forward to going back to work probably sometime middle of this summer. And so as you can see, the neurovascular space has had tremendous innovation over the last 20 years, and we are able to do, many more minimally invasive treatments and save many more lives than we've ever been able to do before, and one of the things I'd like to highlight is our team at NSPC Brain and Spine Surgery is developing a digital CME platform, which we are launching this month. And so we've got some pamphlets in the back. And so we've been working this last year trying to develop ways to educate the community, to share case studies, and also provide free CME credit. And so our NSPC CME Now platform is launching this month, and there's pamphlets in the back. This is our vascular team. We've got a team of 6 highly trained and experienced physicians in all aspects of neurointerventional radiology, Dr. Paul Spellman, vascular neurology, Dr. Choi, and then open brain surgery with Dr. Grant, Dr. Brisman, and Dr. Michael Brisman. Thank you very much.